discussed antimicrobial stewardship opportunities specifically for respiratory tract infections. So why focusing on respiratory tract infections? So I think it's quite obvious. It's the most frequent infection occurring in a nursing home if we take the winter season. And it's also one of the most reasons of inappropriate prescription. And that's not to blame a physician. It's just that it's impossible without having tests available in the nursing home to identify residents who will really benefit from antibiotics. Usually we say it's those with bacterial pneumonia, they will benefit from antibiotic, while all the other with more like bronchitis or viruses, they don't need antibiotic. But how to identify this resident? That's really tricky. So we did a study. So we joined our forces between Geneva and Lausanne. So we included residents with respiratory tract infections in 24 nursing homes in the canton of Vaud and 6 in Geneva during winters 22-23 and 23-24. And we had a research team, so 2 MD students, so 2 MD physicians, and 1 study nurse, so Dr. Alexia Roux and Dr. Nicolas De Pasquale and Joël Luder for Geneva, and they went to all nursing homes, so they were traveling all around Canton de Vaud and Geneva to go within like 24 hours of the start of respiratory tract infection to do a lung ultrasound. So they did a lung ultrasound to all these residents to identify those with pneumonia, so meaning those who would benefit most from antibiotics. So in fact, lung ultrasound, as was said before, it's a very good tool for pneumonia diagnosis. So you can see the sensitivity 90%, specificity 91%. So in fact, it's much better than chest X-ray that we are usually using. So quite a strong reference standard. And so we looked at prescription. So we had like 55% of this resident receiving antibiotics, while only 13% really had pneumonia. So we can see that there is room for improvement. But how can we improve prescription? How can we better guide physicians to identify these like 13% high-risk patients who really need antibiotics? So we evaluated different tools, so host biomarkers, radiology, and microbiology, always keeping in mind that these tools should be scalable, sustainable, and really be usable in the field of long-term care facilities. So there was this study published in 2021, very nice study from the a Dutch group who studied point-of-care CRP to guide antibiotics in nursing homes. So they had 11 nursing homes in the Netherlands, and they randomized the nursing homes. Some nursing homes, they had access to CRP, and some nursing homes, they did not have CRP access, and they looked at the impact on antibiotic prescription. And as you can see, huge impact. So from 82% of probability of receiving antibiotics when having a respiratory tract infections, it dropped to 54%. I don't show you the safety data, but the outcome of the patient was exactly the same between the two clusters. So we can say safe reduction of antibiotics. But we questioned ourselves, can we really extrapolate this data from the Dutch setting to the Swiss setting, which is in fact quite different. In fact, in the Netherlands, they have dedicated medical staff in the nursing homes. So meaning they have a physician available 24 hours on 24 to see a patient if necessary. So they evaluated all these patients, so they had access to the clinical evaluation and the CRP to decide on prescription. While in our setting, I mean in most of other settings, it's mostly based on GPs having their own practices or physicians working for the long-term care facilities, but also having their actual practice, so they cannot come anytime to evaluate a patient, so they will maybe come 2 days later or do a decision through the phone, so it's very different. So we said maybe if we can develop a score based not only on point-of-care biomarkers, but including some vital signs, it could like kind of replace the medical evaluation and still guide prescription in these settings lacking on-site physician. So we tried to develop a score based on vital signs and point of care biomarkers to predict pneumonia, but mainly to guide and optimize antibiotic prescribing. So that's the score, the best score which came out our analysis. So it's a 5 variable based score, so based on the age, in fact, which was related to a higher risk of pneumonia. Then nutrition, so with a low BMI, which was also associated with pneumonia, an elevated heart rate, an elevated respiratory rate, and a high CRP value. So these 5 markers were independently associated with pneumonia, and when combining them, we had quite a good score. So using this score, so we could categorize patients in 3 groups. So first, the low-risk group, 0 to 1 point, the intermediate risk group, 2 points, and the high-risk group, 3 to 7 points. And the recommendation would be, so if you have a low risk, no antibiotics. In fact, a third of patients fall into this group. If you're in the intermediate risk, you need a follow-up or maybe an on-site evaluation. It was in a third of patients. And high risk, then in this group, probably antibiotics are recommended, and it was concerning a third of our population. That was the performance of the score. So sensitivity and negative predictive value were quite good, so 86% and 89%, so meaning it's quite safe as a score. Specificity 77%, positive predictive value 71%. And then we compared our score to a CRP alone score. So you can see the 5 variable diagnostic score performs better, so it's safer, higher sensitivity, higher negative predictive value, because I think that's really what we want, so we don't want to put our resident in a danger situation. And you can also see that with the 5 variable diagnostic score, we had less resident in this intermediate score when you need maybe additional follow-up. So I think it's promising. Then we have to discuss, is it implementable? So we need to look at vital signs to measure respiratory rate, heart rate. So this will be need to be evaluated and discussed about the feasibility of implementation. We also looked at radiology. So lung ultrasound, as said before, it's quite challenging right now to implement lung ultrasound because physicians are not trained. And if we speak maybe about people being in the long-term care facilities, so nurses, they are not trained at all in using lung ultrasound. So there is a challenge for image acquisition and also for image interpretation. So how can we help them with that? So for the study, we use a standard 10-point image acquisition protocol. So it's time-consuming, not so easy because you have really to see where you put your probe, that you have a good quality image. But we also evaluated what we call blind sweep. So it's just putting the probe on the thorax and sweeping the probe, like a 10-second sweep. And you do it like 3 times on the left, 3 times on the right, and that's really easy to perform. And we wanted to see, so if we do this easy image acquisition protocol, but is it as performant as the standard protocol? And in fact, it is, so you can see it's very sensitive, 97%, highly specific, so again, excellent negative predictive value, so it means it's quite promising and it's much easier to implement and less time-consuming. But now, what about image interpretation? So could we use artificial intelligence to help us to identify consolidation on lung ultrasound? Because that's what we are looking for, it's this consolidation. And it's not so difficult to see, but if you are not trained, it's challenging. So we compared like expert-based interpretation to AI. And in fact, as you can see, AI really performed really well with an area under ROC of 0.95, so excellent performance for of AI-guided pneumonia detection using expert interpretation as a reference standard. So I think it is promising. So maybe in some years, we'll have like an app on our smartphone. So we have already the probe that we can plug in our smartphone, very easy to use. And maybe it will be done even by nurses or people being in the nursing homes. Yeah, the last one is microbiology. So could we use this PCR, viral PCR test also to guide antibiotic prescription? So we did another study. It was a retrospective study using data from 45 long-term care facilities, including 2,400 beds between 2021 and 2023. So that was the work of Marc Jeanneret. And as you can see, we did not find any relation between, that was about COVID testing, not influenza testing. We wanted to see if there was a link between a higher use of a rapid test for COVID and less antibiotic prescription. So in fact, testing for SARS-CoV-2 was not associated with antibiotic prescription, so no differences between nursing home which tested more for SARS-CoV-2 compared to the other. But we saw clear link between positive testing for SARS-CoV-2 and less antibiotic prescription. So in fact, the conclusion was that you need to test 3.5 resident positive to avoid one antibiotic. So meaning that probably it's worth testing for COVID and probably also for influenza during outbreak. So when you have a high prevalence of positivity, to guide your prescription, so avoiding antibiotic prescription in those with a positive test result. So to conclude, I think we have diagnostic tool, so CRP or clinical CRP score or AI-guided lung ultrasound, viral PCR testing, but probably we need still some clinical trials to demonstrate that they are impactful when we implement them, and they are safe, and also to test how best to implement them in this very challenging setting. Conducting research in LTCF, it's challenging. I think it's the most challenging setting I never experienced, so much more than GPs, much more than Tanzania. So that's really the most challenging one. But it's important, so we have to continue. Thank you. Yeah, and all the people who contributed to this work, so that was really a teamwork. Geneva, public health, infectious disease, that was a great team. Thank you.